I've been asked frequently a lot of questions regarding different surgical guides utilized for implant surgeries. So essentially there are three different types of guides. One is what we call the lab fabricated conventional surgical guide. The second one is the computer guided surgery. And then now more recently, more of the newer innovations involves dynamic surgical guides. So I wanted to just talk about the differences and advantage and disadvantage. On a lab fabricated guide, there is a model being made, and a clinician or a technician will utilize that guide, and there's a difference between what is treatment plan on the model versus what is being actually done three-dimensionally within the patient. So there's going to be an interpretation of the three-dimensional anatomy that's required. The computer-guided surgery will give us the benefit of utilizing the cone beams and then to treatment plan the exact position, angulation, depth, positions, and width of implant positioning. And with the guided surgery, the clinician will be provided these very specific guides and or drill sizes that at the time of surgery, we don't have the luxury or the ability to change or misangle. So this is what we call a computer-guided surgery. Some of the issues, of course, treatment planning, additional costs are involved in terms of the computer-guided surgeries. Finally, the dynamic guides. The dynamic guides, what we would utilize is, again, a patient scan imaging of a cone beam, computer treatment planning, so that we, again, appreciate the three-dimensional anatomy or challenges that we have to run into. And then essentially, the clinician will have a lifetime of doing the implant surgery and looking at a monitor where it gives us the information for the depth, the angulation, and position of the implant. If you will, some of the orthopedic surgeons are utilizing this where the surgeons are looking to scope or looking at a monitor rather than in the patient's mouth. Of course, the end goal desire of all three modalities is such that we place the implant in the treatment plan that's desired for the final prosthetic of the implant restoration at the end. And of course, to avoid any clinical or surgical complications and or anatomical limitations.